Is that everyone in the waiting room?
Yes, so far.
Great. Shall we get going?
I think it's up to you if you want to sort of wait for more people to trickle in or if we want to get started.
Might as well get going.
Okay,
They can
sounds good.
join. Hi everyone, welcome to Operations Committee. I'd like to start off by saying thank you for your flexibility meeting on a Friday afternoon instead of a holiday, which I would prefer anyway, and hopefully you do too. As is our usual, we will be efficient today and we will not go all the way till 4 o'clock, I'm sure. All right, there's Mike. Just waiting for a few more. There we go. Okay, Isabel, when you're ready, would you please do the roll call?
Yes, I will. Okay. Judy Richardson.
I'm here.
Thank you. Laura Byerly. Don't see Laura. Doug Flo is unavailable today. Sarah Fouché. I see that
She,
Sarah's
yep,
here, but not connected to audio yet. So for the record, Sarah is present and can hear us. Lori Hoagland.
here.
Thank you. Michael Horay. I don't see Michael. Doris Karagu let us know that she is unavailable today. And Lovejoy.
Here.
Thank you. Paula Weldon.
Here.
Thank you. That's our attendees.
That's great. And we
Oop, did you get Mike?
have
Oh, that's right. Our new and Mike Leahy. Mike, you should be able to unmute now.
Right here.
Thanks, Mike.
thank you, everyone. Roll call is always an opportunity to do a little tech check in this day and age. We know that things can happen on the Zoom, and so thank you very much. And I will repeat my gratitude again for the group for your flexibility in joining today for the hard work of this committee. All right. I'm looking at the meeting instead of the shared screen. There we go. Here's the agenda. So we're going to have some board updates. We're going to talk about an operational lens looking at primary care and behavioral health models of integration. We're going to talk a little bit about eligibility and enrollment. Mimi's going to walk us through our transition to the transition committee, and we'll have any committee member reflections, talk about next steps for this work, and any public comment. Are there any changes to the agenda or can we proceed? Hearing none, go ahead, Executive Director McDonald.
All right. Hello, everyone. This is Mimi McDonald. Nice to see you all. And again, also gratitude for coming on a Friday. Today, I'm going to present, as I often do, our what's happening at the board level and also with all the other committees. So we had a jam-packed board meeting yesterday, which was fantastic. The board came to an agreement on a mission statement, which I realize I probably should have made a slide of that. Apologies. I'll find it a little bit later. We can maybe share it at the very end. There's also a discussion about the annual report to the legislature that Helen Belanca and Judy Richardson and myself were able to deliver, which went great. There was a board communications policy update discussion, and then there were count them, four straw proposals, which actually all went through. An administrative structure proposal, thanks to you all. There was also a quality straw proposal, revenue straw proposal, which is still in the works. It's still, that one is super iterative, and then a hospital payment proposal. So I'm going to stop just for a sec and see if our two board members who are there have anything else they'd like to share about the board meeting.
No, thank you. Like you said, Mimi, it was full, and props to this committee for your hard work and patience with the straw proposal that waited through to board meetings to be presented. But our description of regional entities was endorsed by the board, so we will proceed along that path.
All right. Also, let's see what's happening in the other committees. Finance and revenue, as I mentioned, continues to further develop and refine the revenue strategy in response to comments from just great comments from the public and also from the board. So I think it's really coming together. It's really exciting. Our consultant groups and also some of the committee members are working on that distributional analysis. So for individuals and businesses, in other words, if we do this, we come to this revenue strategy, what will it mean for people with different income levels or employed or self-employed or, perhaps in the Medicare age range. So that is also happening. Also getting a lot of information, especially from Echo Northwest, our consultant group, about the reserves that are needed to enable a startup of a universal health plan. So that's cooking along. Plan design and expenditure. They did a lot of the heavy lifting for getting through the quality straw proposal and the hospital payment. Also, at our last plan design and expenditure meeting, our consultant group Milliman gave a great presentation with their initial updated estimate. So as you guys may know, we've been using information from the Optimus report, which was created for the Joint Task Force report. So that was 2019 data, which was presented in 22. And that is what the Finance and Revenue Committee, has been using as sort of as the kind of target at which to sort of align their cost structure. So now Milliman is using 2023 data and all parallel claims data system, which is fantastic in Oregon, to provide what will be an updated cost using the plan design and expenditure. So far, the current plan design. And they, had an initial estimate. There's some changes that were needing to be made. And so then at the next meeting, they will come back again. So that's actually just right around the corner at December 4th with I would say, a refined estimate of what the cost is, which of course is going to be imperative to really have a good handle on that so we can know what kind of revenue truly will be needed. And then lastly, the community engagement and communications team has very impressively completed almost all of their deliverables. They've done all the deliverables for communications, and there's lots of materials that are available for that. That committee itself is taking a short hiatus. They will be back in April, but the work of that committee, the community engagement work, will be carried on with the consultant Diana Bianco of Artemis Consulting, who is going to be developing and then implementing these small group meetings with the legislatively required groups to get that really important feedback about where the plan is at right now, getting feedback so then it can, again, be iterative process. So much, but just wondering, any questions or any other
Thank you, Director McDonald. Any questions for Mimi? Thank you for your role. All of these work streams are barreling down the track at different paces, doing different bits of work. And Dr. McDonald really provides the nodes of connection between each of these. So you may listen in to other committee groups, but we really appreciate your work and attention tying these together and the work of the different committees. Questions? Okay, we can move on then to primary care and behavioral health operations. This is one of those elements of the work streams that cross over. If there's a Venn diagram between all of the committees and their work, this one really does bump up against and overlap elements of plan design. However, thinking about how to build and integrate primary care and behavioral health from an operational perspective is really in our wheelhouse. And then we can collaborate with and have touch points with plan design and work together with how they see that the plan implemented, we can design the operational structure around that. So I've asked Lee, our fabulous policy analyst, to senior policy advisor, to help with these slides. And so I'm gonna pitch it over, Lee, when ready.
All right, thank
Proceed
you
and
so
describe.
much. All right, and let's dive right in. Oh,
Different
actually,
Sorry about that. I think this is
I can go ahead and share my slide.
Okay, you want to, oh, would you that? Thank you, Lee. I apologize. Should have warned you.
While she pulls that up, I'll talk about the rationale behind designing 3 different models. It was really kind of based on our experience with the patient-centered primary care home, and knowing in Oregon that's been a really solid, robust model for primary care. The behavioral health piece has been tricky to integrate well with primary care, and especially as we look to the state, the resources are variable across the state. There are some places that have strong primary care resources. I don't think there's any place in the state that has sufficient or over amount that they need, but there are certainly areas of our state that have none. And so thinking about how folks who live out in those more remote frontier areas, rural areas, or even perhaps suburban areas where resources are constrained was kind of behind the operational thinking with these models. So go ahead.
All right, thank you so much. And huge thanks to Dr. Richardson for a lot of work helping to just put these options together. So I put them on slides, but that's all I'll claim. So as mentioned, this is really all about how to integrate behavioral health and how to do so specifically within the administrative structure that this committee has proposed and that the board has approved. So really looking at how we can develop this unified approach to physical and behavioral health, avoiding some of those kind of known pitfalls that we've encountered from the CCO model, and really utilizing those regions in a way to make this as effective as possible. So a handful of guiding principles here, and some of these drawn directly from what we've already discussed related to administrative structure. So just a reminder, this committee and the board, I think, all had strong agreement about the central public corporation holding all financial risks. So we always want to reiterate that. We know people have strong feelings on it, and I think we're all on the same page there. Also, as noted, different parts of our state are really, really different with respect to the kinds of resources that they have available. So wanting to leverage the fact that we do have regions to let them make some of those choices where they can find kind of a best fit, depending upon what they have available and how much ownership they feel they are able to take in this area. Another guiding principle is really using these patient-centered primary care home and certified community behavioral health standards. Based on the board-approved proposal related to primary care, we know that primary care providers are going to be operating under the primary care value-based model, which does include these various standards of primary care homes. So trying to be really consistent with what the board has already approved, essentially. We're really building something that is going to be integrated. And then some lessons from our current model, just wanting to be sure that members can choose their primary care as well as switch freely, and keeping that attribution clean and allow members to be able to move while preserving continuity of care. All right, so what we have prepared for you are essentially 3 options, but I think it's really better to think of them as existing on a continuum, because it's not that you just have to pick 1, 2, or 3, but you might fall somewhere between, 1 and 2, or between 2 and 3. So really having that customized level. So the idea is that regions would be able to select which model they have based on their capacity, and that they could kind of blend elements as appropriate, again, based on their resources. So having that flexibility along with that statewide consistency, that's really the proposal that we got from this group before on administrative structure, and we want to make sure that the primary care and behavioral health reflects that. So under Model 1, which I would refer to as kind of the fully integrated model, this would be a region that has just really strong resources, really high capabilities, able to have a local integrator that coordinates the primary care and behavioral health and really forges those connections. So again, ideal for those regions that have truly robust infrastructure. Model 2, which again, existing on this continuum, we're just going to say somewhere around the halfway point here. The virtually integrated network, where there is strong digital integration, but the region may have a lot more fragmented kind of resources relative to behavioral health, or they might rely on telehealth quite a bit more. I'm thinking just Central Oregon, where there is Bend, where there's a lot of resources, but outside of that area, there's maybe not quite as much going on and a strong reliance on telehealth. Model 3, which would be at that far end of the continuum, this is our sort of community home mobile extension. These are going to be for regions that don't have a strong local infrastructure, probably those rural and frontier regions out in the far eastern part of the state. Here, the state would be able to step in, or the public corporation, I should say, would be able to step in and provide more support. They would help with kind of an IT framework behind that, as well as offering kind of mobile and virtual behavioral health options to ensure that capacity can be met for those areas. And this is just another way of presenting all of that, but just noting these are kind of the three different options and the different sort of regions that they would be a fit for, what that core structure looks like, noting some differences in that payment approach, as well as some differences in how attribution is handled for those various patients.
And Lee, I just will pipe up here. The reason attribution is important is not due to risk. So we said the central universal health plan bears the financial risk. But it's important to know where folks are getting their care, because we hope to reward outcomes and quality to that clinic, that region, based on how those members are doing. And so it's important to know where they're getting their care, as well as developing continuity, and having their own medical home where they're known and they get the care they need. So that's why we're talking about attribution here. Not so much as we think about attribution in the CCOs, like who's on the hook financially for providing the care and who's gonna pay when they come over or under. That's kind of a one way to think of attribution, but in this case, we're thinking about, like, where do folks get their care? Yeah, Mimi, sorry.
Oh, no, I was just going to add in too, and people on the call are probably very well aware, but a lot of some of the care providers in behavioral health, and certainly the care providers throughout in primary care clinics too, are not necessarily individuals sometimes who are licensed, certainly in the behavioral health space. And so creating a system in which those folks are able to be paid, not necessarily on a per diem or per case basis. That's the other reason. So again, just as Judy said, the attribution is not on the hook, but it's really to be able to put the money into the population where they are.
Awesome. Thank you both so much. So there's a lot here, but also want to be respectful of time. We can certainly return to that during discussion if needed. And just to note that relative to this proposal and what it would look like to go from where we are now to something that looks like that, this committee, as part of its work on doing the administrative structure, had discussed maybe coming up with some additional criteria to define regions. So if that's something we wanted to do, we certainly could continue with it. But a first step, of course, would be having those regions and determining what that behavioral health capacity is at present. Is it, in the high range, medium, or is it on that lower end? And using that, we could do kind of a basic initial, assignment to one of these models. And the region, of course, could have discretion to change it if they feel that there's a mismatch or that they have more or less resources or want more or less support in doing this. Developing a unified set of standards and measure set from provider groups, of course, and the board just recently approved a really fantastic proposal related to quality strategy. So this would be kind of a component within that as well. And then very importantly, and a lot of this does tie into broader work that a universal health plan would have to do as well, but making sure that we really have the digital component in place, whatever IT needs are there, especially when it comes to some of those, Model 2 and 3, the public corporation is taking on more of that functionality to support the region. So we want to make sure that, if we're offering it, we're actually able to support that work and ensure that this integration is happening. Yeah, and then a lot of those kind of technical details as the system is being set up, having those patient loads, running payments, and then, of course, having that data aspect because we really want to be able to monitor what's going on, have those metrics, not just to see if the system's working, but also where it can improve and to be accountable to the public. And the anticipated timeframe for that, 12 to 18 months. And I believe that, yes, is the last slide. So I'll turn it back to you, Dr. Richardson.
And so the other reason we're talking about this now is because it helps to delineate and define those roles between the central universal health plan entity, the public trust, and the regional offices, and really shifts who does what and figures out how those roles work together and who provides support and backup and extra resources if it's not available regionally. The ask to the committee is really just to get you to start to noodle on this and think about, is there a model we're missing? Did we miss something? Can you think of a scenario in Oregon where none of these would fit? Or is it unclear what we're thinking about and proposing? This is not a straw proposal at this time. However, it might be something we collaboratively build with plan design as a straw proposal. It would, with their input, talking about network adequacy and adding in the benefit structure together may make sense as a joint straw proposal. So go ahead and stop share and we can see each other and see if there are any thoughts or questions or input about that. And apologies if we went through it a little fast. We've kind of been eat, sleep, drink, breathing this. Hi, Lori. What you got? Unmute. I can see that you're trying to unmute, and thanks for joining even from the car. I can tell it's a busy day.
Okay, I'm unmuted. Oh, good.
Yay.
Okay. So there's been a lot of concern with mental health in terms of inpatient issues. And I'm just wondering how much conversation has gone into as when you're dealing with a system that's kind of in crisis now, and then you're transitioning to something else. Of course, the hope is that in the process, maybe we'll be able to mastermind and repair some of the problems with the new model. But I'm just curious with the idea of perhaps having a lot of flexibility with moving patients from frontier or rural areas into more resourced areas for instance, inpatient mental health or SUD treatment, things like that. If there's been any conversation with that or, how that looks with these three models.
I really appreciate the question. The answer is no. I approached this with a bias that Dang it, basic behavioral health, in my opinion, is very much like, doing an annual physical checkup and, physical therapy after you break a limb. Like, just about everybody needs it, and so we should build it into the model. And there's this kind of mirror in the behavioral health world to the patient-centered medical home that has already established metrics. So I was thinking about establishing that basic base of the pyramid first, and then from there building up to more high intensity needs in specialty care, like both, like as you go from primary care to specialty care and you need more intense behavioral health services or even hospitalization. How does that build out of that? This is the basic benefit package to start the floor. So thank you for that question. Yes, we will need to talk about it, but this model does not address it.
Okay. I strongly encourage, and I will do my part to get NAMI involved with some of this, because there's a lot of nuance with mental health services that is different than primary care, and probably much more complicated in some regards. Anyway, thank you.
Thank you. Mike,
Hi, can you hear me?
we can hear you.
Okay, I want to build on that comment and recognizing this is my first time as participating in the operations committee. I've been looking at some CCO data and some state data, and then I asked two different psychologists to comment on this data, and I got the same response. So I'm wondering if you guys have already covered this, and that is there's a lot of people that go not just to unlicensed, but to licensed people where I believe neither the CCO nor the state is capturing this data. I'm trying to get a better sense of this, but at least I have two data points where people are saying is maybe we are estimating the amount of interactions that are going on by using formal data. And if that's so, of course, then depending on our benefit package, how we then handle that, what are the financial implications? There are a number of other questions, but my question, I guess, is what do we know about how good the data is about where people are getting counseling, therapy, care?
Well, I don't quite know how to answer that question because we haven't looked at this kind of data. And I'm wondering if, certainly in finance and revenue, working with our consultants and the actuaries, looking at current costs and expenditures in healthcare in the state of Oregon, they'll kind of get to that element and we'll want to know if that's a black box that they don't see, right?
Okay.
I think from an operational perspective, it's critical to know what the resources are as we're recommending operations to support network adequacy. As far as utilization goes, this may be an area where we call on the expertise of other committees like plan design and finance and revenue.
Mhm.
Yeah, Mimi, thank you.
Oh, yeah, Mike, just a clarifying question. So were you referring to people essentially who are paying for services out of pocket,
Yes.
for services that aren't being billed? Okay, so that's
Yes.
what I thought that you were referring to. Thank you. Just want to make sure.
That, and then to a lesser extent, people are getting counseling and other interactions that may or may not be billable. I'm thinking, for instance, years ago we did a study within Kaiser, and we're amazed at how many whole consults were occurring that were not documented, as an example.
Yeah, thank you for that. Other immediate thoughts come to mind. I wanna send this out to you and let you think about it and wake up in the middle of the night and jot down some notes and come back and say, wait a minute. Or we can continue to flesh it out and build it and connect with plan design. Don't wake up in the middle of the night.
Yeah, I just
Yeah,
have a
Anna.
question. When they set up the quality plan, did they talk about accreditation?
Oh, Mimi, can you address this question?
Yeah, and so the quality, it's actually, once again, being a little bit meta, that seems to be my role. It was actually how to create a quality policy and a quality strategy. So it wasn't so a plan was not created, but it was all the building blocks for that, and accreditation is mentioned in the white paper of it, because that certainly is part of it. And there's certainly lots of accreditation agencies. And then, of course, for all of the, especially in behavioral health, there's lots of different types of accreditation.
Yeah, and that's kind of a short circuit because you can just adopt by reference the standards. And that's also a way of keeping current, if that's part of your strategy, in other words.
Well, it was,
To
yeah,
require-
part of it was definitely to use sort of evidence-based guidance. And anyway, I don't want to go,
No,
it
that's
is a
all
lot,
right.
but yeah,
All I'm saying is you don't have to invent it. You don't have to
exactly.
reinvent the wheel. That's all I'm saying.
100%.
Hi, Sarah.
Can you hear me?
Yes.
Okay. Sorry if this is a bit naive, and if I'm going too far into plan design, but the way that in like oral care, there's a continuum between like medically necessary work and, let's say, cosmetic work, and how do we draw those lines at the plan? And then in behavioral health, let's say somebody has a mental illness that everybody agrees needs medically necessary behavioral health. And then let's say somebody is doing really great and feels really healthy, but they want to do dream work with a psychotherapist, or like very personal growth work that most medical practitioners wouldn't deem medically necessary. And I'm wondering how we're going to carve out coverage versus non-coverage.
I love this question because it gets the nuts and bolts of really what they're trying to figure out in plan design and matching with finance and revenue. So if we can generate this much revenue and we can provide this much benefit, and where do you draw those lines? And historically in Oregon, we just have such a long history of like OHB and drawing the line and stuff. I would connect.
A long history of what?
Oh, sorry, of the Oregon Health Plan and the prioritized list, and where do you draw the line, and how do you justify what is medically necessary and what is not, and what is improvement of quality of life, which may be someone's definition of medically necessary. It's like, how do you draw those lines? And I think when excuse me, push comes to shove, what do we have the funding to support is a key one. And then what is also medically justified, standard of care, all of those elements too go into those decision making. And this is exactly the work where plan design is trying to figure out, how do we make those decisions, like stepping back and not making this is in, this is out, but how do we evaluate and judge as a community, as a state, what gets covered and what doesn't, and what's in and what's out. And I hate that it sounds like a hedge, but that's kind of outside of the operational wheelhouse. So yeah, we can definitely ask those questions. In fact, it might be really interesting to invite Dr. Blanca to talk to this committee on behalf of plan design and bounce the ideas off of her. I don't know if she'd need to even come into the committee, but bounce those ideas off of her with the models and ask, is this fitting what plan design is thinking? And then plan design develops that structure. They love input too, and so any of us can watch plan design committee meetings and chime in too. So that would be a really interesting conversation to have, especially when it's on their agenda topic and talking about, bring up that example, Sarah. I love that. So interesting. You have anything else to add there, Mimi?
Yeah, I mean, it is definitely a good point. And there is some operationality to all of that. There are certainly things that, for example, I'm not sure of any health plans that cover something that is considered strictly cosmetic surgery. But as you know, there's, even one procedure may be considered, the same procedure could be considered cosmetic, and then, or else it could be not considered cosmetic and medically necessary. I think we could think about reconstructive surgery, that's breast reconstructive surgery because of cancer or not. So there are, and utilization management. So this is what a lot of the work that I did when I was at my previous job with a health plan, and making those kind of guidelines. Sometimes it's around, again, sometimes it's relatively easy. Yes, this is covered. No, this is not. But then you're like, well, okay, this is covered, but for how long? And then, okay, well, we'll cover the first 6 visits or 12 visits. I mean, it is a lot. And then you get back to the also simplicity question. Well, I have yet to meet the patient or provider who loves prior authorizations, because they are administratively burdensome, but there also can be a rationale for them. So I just feel like there's so many tightropes around here that we're all going to be walking in while juggling plates at the same time. But again, there is an operationality to that, because you have to build that into your operations plan, because that question won't go away.
Other thoughts? Well, I propose we sit on these models and think about them, and add in the questions, Sarah, that you asked, like, well, how do you need to iterate the operational structure based on like what you decide to cover, those kinds of things. And how do you account for hospitalization and higher levels of care? Oh, yay, got some hands. Go ahead, Lori. Oh,
Okay, so I'm thinking about being a provider as the ACA rolled out, and what was initially approved really evolved with time. And so I think we have to acknowledge that flexibility is going to be a big part of this, because, initially people make assumptions. For instance, chronic back pain, get surgery done. Well, guess what? Physical therapy and mental health, some of these other things may actually be more successful and less expensive and less risky. So I think that, to me, it seems like there has to be just constant quality evaluation as things emerge and therapies change and their popularity and their research results.
agree 100%. Yeah, medicine changes, right? Sure. Go ahead, Anne.
Yeah, I had a question, Laura. You mentioned substance abuse. Did you think that needs like a particular description within the models? Because it is different in some ways from mental health per se.
Well, there's lots of dual diagnoses, as we know, so it's really hard to look at it in a totally separate context, because there's patients that have to work with both problems. And I guess, there's that additional cross section with the justice system and deflection and some of the other approaches that are now occurring. And I guess that partly led to my thinking about regionalization, because depending on where you live, things happen quite differently. And you have to kind of pay attention to the resources and the opinions in the community. It's a lot more complicated, and it's under resourced, and the intersection of nonprofits and their role versus our statewide, who belongs under the umbrella and who we interact with outside that umbrella. It's complicated when it comes to these plan design.
Thank you, Lori. Go ahead, Sarah.
Yes, there was a slide that talked about a 12 to 18 month timeline, and starting when? What's day one of the 12 to 18 month timeline?
Lee. Sign legislation to 18 months. Is that what it is? I guess that was mine. pulling on implementation of the CCOs, and when they started awarding PCPCH per member per month bonuses essentially for folks who are trying to establish as a patient-centered medical home was at least a year and a half. But even that, it was iterative, right? Because people kind of applied and maybe had all of the requirements or were working on some, but it was a gradual rollout. What do you think, Lee?
Yeah, this is a little bit of behind the scenes early info, but I have started some research on transitions and implementations, and generally it's 1 to 3 years from when legislation passes to implementation occurring. So it's kind of in line with that sort of process of the legislation passing. When do these things actually roll out?
I figured it was from legislation passing, but just didn't want to assume.
It's a great question, right? I mean, the work before us is monumental, and the change we're asking this state to do is blows my mind on a regular basis. Cool. Well, I'd like to move along in the agenda, if that's all right with everyone. We'll come back and revisit this idea even in December. We'll send out with the meeting reminder any specific ask, or if you have other questions or ideas that come to mind, send me an email. I'm happy to think about them and incorporate them and build that in as we move closer towards either a straw proposal or a collaboration on a straw proposal with plan design. Up next, eligibility and enrollment. Go ahead, Lee, Senior Policy Advisor Hastings. Thank you.
All right, thank you. Yeah, let's dive right in. This is something that we discussed quite a while ago, but we're revisiting because the board had some questions on it, particularly around that enrollment piece. So presenting some different options specifically to get feedback from this committee. So the context here, of course, starting with the Joint Task Force, was that the Universal Health Plan would be available to all people who live in Oregon, regardless of job, income, immigration, or tribal membership. So a couple of these special categories that are included, because just wanting to make sure that we're really capturing everybody who lives in Oregon. Of course, Oregon's members of the 9 federally recognized tribes, also out-of-state students that are attending universities or colleges in Oregon, coverage for dependents of Oregon residents up to age 26, so aligned with that ACA provision, coverage for seasonal farm workers while they are working in Oregon, and coverage for individuals that are incarcerated within the state of Oregon. Next slide, please. Now, when it comes to residency, there's a lot of definitions. These are just 3 of them that are amongst the more rigorous, just presented here as kind of an FYI previously. And the recommendation is to stick with the definition of residency that has the star on it, which is the one for tax purposes found in ORS 316.027, which is essentially if you are domiciled in Oregon or maintain a place of abode where you reside 200 or more days of the year. The voting purposes, you can see there's kind of a lot of overlap, especially when you look at that lower bullet, which is the address from which you file taxes. So that kind of ties back Oregon driver's license as well. But the tax purposes is, you know, we do believe the most rigorous of these, although there are other definitions, of course. Next slide, please. Now, just to take a little bit of a deeper dive into these special resident populations, because previously we did have some folks just curious, you know, we're adding all these different groups into what we consider to be Oregon residents. What are we actually talking about? So, of course, members of the 9 federally recognized tribes, that's really not a huge amount. Those out-of-state students attending universities, I'll note that that number right there is just from public universities. It's very hard to extrapolate to private because private does tend to have more out-of-state students. Some really ballparky numbers would put it at 60 to 70,000 though. So that's kind of what we're looking at. Not a huge amount, but you know, it's something. Persons incarcerated in Oregon, about 14,000. Seasonal farm workers, again, a really tricky number. But from one survey that's probably the most reliable thing I found. It was about 174,000. And then just looking at veterans as well, given that they also have that alternate coverage, that's kind of a more substantial group at about 266K. The double stars there just indicate about half of those folks are also Medicare eligible. So that's kind of a consideration as well. So on the whole, you know, these special populations really not a significant portion of the, 4.3 million people that we have in Oregon. Next slide, please. So just related to eligibility, again, just noting we're not recommending any changes, but did want to represent it to this committee since it is so related to the enrollment. All right, next slide, please. The next one. Great. All right, so moving into enrollment, and this was something that under the previous proposal was not included at all. So we are kind of discussing what are these enrollment processes possibly going to look like. The Joint Task Force had stated that they want no waiting period for benefits and residents to enroll when they move to Oregon, when they access care, as long as they can attest to their intent to remain in Oregon for a period of 200 or more days. And that is, of course, aligned with that eligibility definition that we saw of being in Oregon for 200 plus days of the year. Also noting that minors would be enrolled when a guardian who claims them as a dependent signs up for care. So the board had a number of questions about this, such as information on different attestation systems, how to make it easy, and what does it look like for OHP? So let's dive into that. So OHP eligibility/enrollment is really based around these three things: financial criteria, proof of residency, and proof of citizenship. Financially, of course, Medicaid is a means-tested program, so you do need to fall below a certain income in order to be eligible, and you can see the kinds of forms that they accept as proof of this, things like tax returns, W-2s, other financial documents that can demonstrate what your income level is. Residency, of course, they want you to be living in the state in which you are applying. So you're not going to get OHP if you live in Vancouver, Washington, for instance. And this is generally proven through a sort of utility, something that shows your address. So a utility bill, a bank statement, or other kind of official document that you would receive, presumably at your place of domicile. And then citizenship, needing to be a U.S. citizen or fall within a certain category of qualifying non-citizen. So able to demonstrate that via whatever government issued ID or birth certificate you can provide. Next slide. Now looking at our other key federal program, Medicare, this one's a little different because we have, kind of a mishmash of automatic and manual enrollment. Essentially, one is automatically enrolled into Medicare if they're already receiving Social Security or these Railroad Retirement Board benefits prior to turning 65. At that point, the government is well aware and they will auto-enroll you. Manual enrollment is required if you are not within that category. Now, I'm not an expert on Medicare. My understanding is that Part A will kick in automatically, but it's really that Part B piece that you need to be manually enrolling for. And if you do miss that initial window, you can sign up, but it generally has to be within that specific enrollment period of January 1st through March 31st of each year. When enrolling, you can see in that blue box, apologies for the kind of small font there, but you need to be able to provide this basic information about yourself, Social Security number, where you were born, essentially to verify your citizenship and eligibility, and any health insurance information that you currently have. Next slide, please. All right, so now we're going to get into a couple different enrollment options. There are going to be 5 options. They are not necessarily mutually exclusive. So there is the possibility that you could combine, for instance, option A with option C. Just to keep that in mind, there's a lot of information here. I'll probably go through these 5 slides quickly because then there is a table where you can kind of see all of them together. And I think that might be an easier way to really get a sense. But our first one that we present is option A. This is the simplest option. This is your immediate coverage, no waiting periods. It begins the day that you attest to your residency or your intent to become a resident. So really leaning into kind of some of those Medicaid rules where you're not allowed to have that waiting period. This would essentially apply that logic to every single person. Verification under this would be kind of a, you know, a basic attestation with a time limit to provide that evidence. But even before you do provide that evidence, that coverage would be there. Obvious pros, this is the simplest. It's, very easy to understand, relatively easy to administer, and it does maximize that coverage. Cons, it does require some work on the backside to make sure that those that have attested are actually, valid folks that are living in Oregon and able to get coverage. Next slide. All right, enrollment option B, this is inspired by a policy that actually exists in Switzerland. And this is essentially that you must enroll within 90 days of establishing residence. So this just really encourages people to stay on top of it, to make sure that folks are enrolled, that they're not showing up and having to get enrolled at the point of care. And there would be a small surcharge that applies if you do delay in getting this coverage. There would, of course, if this was an option that we chose, we would want to consider different equity exemptions for certain folks, such as those that are experiencing houselessness, survivors of domestic violence, migrant and seasonal workers, and students. This does keep immediate access, and it creates a deadline that can help improve as well the documentation and integrity of the system. It is a little bit more complex, and communication with those moving into the state would have to be very, very clear in order to avoid seeming punitive potentially. Next slide. All right, so option C, our third one here, this is a phase-in benefits. So essentially, one, as soon as they enrolled with the universal health plan, would not necessarily have access to every single benefit that is available, but those really kind of core primary care type benefits, they could start to access immediately. One of the thoughts behind this, there is fear from some people that having a universal health plan will trigger a lot of people wanting to, move into Oregon, say that they're a resident, get really expensive care, and then quickly leave. This would be essentially one way to prevent that by saying, well, you can't have your really expensive, procedures unless they're absolutely medically necessary until you've been here for 6 months. Also, equity exemptions would be important here for certain people that do have very high risk diagnoses, of course. We don't want to create any kind of bad situation in that respect. It creates some budget smoothing. So again, preventing people from moving here and just really taking advantage of this and getting all their care right away. They would, of course, have access to those primary services, but saving any really extensive treatment that is not immediately medically necessary for after that 6-month waiting period. Cons, of course, whenever you add some kind of phasing or some kind of different status to people, it becomes slightly more administratively complex. So that is something that would have to be managed. And there's also the aspect of communicating with new members, making sure that folks really do understand how this works so that it doesn't create kind of dissatisfaction there. Next slide. All right, option D, I call this coverage rollover. This is really kind of targeted for specifically those populations that are currently receiving some amount of federal healthcare support for their coverage. So this option really endeavors to create as much continuity of care and as much smoothing for those folks. So if they had credible coverage, such as Medicaid or marketplace coverage in another state, to immediately roll them over into the Oregon health plan with essentially just the verification documents of their prior coverage. So a way to really smooth that process for a certain subset of folks. This would, of course, reward that continuity and reduce gaps. The challenge, of course, is getting that documentation from other states, or in some cases, these individuals may not have that documentation readily available. But it is an attempt to kind of smooth coverage for folks that are coming in with credible coverage that did have federal dollars attached to it. Next slide.
Lee, I'll just stop.
Yes.
Back that one. Sorry, I'm really trying not to put acronyms in slides and the information, but the CMS TMSIS is a database of shared information for folks who receive federal benefits that the Universal Health Plan could access through a data agreement. We've done a lot of research with that, like pulling from federal Medicaid data, especially. So.
Fantastic, thank you. All right, move on to E and then that summary table that I promised you all. So hopefully that'll make a lot of sense when you see them all side by side. This one is essentially a 12-month dividend. So it differs a little bit from what we talked about before with C, because honestly, this could be structured a lot of different ways. I don't know how many of you are aware, but in Alaska, they have a dividend model where each year, like literally every resident of Alaska gets a check. And this could potentially be the same. It could be a health savings account. It could be just literally a cash check. Or it could be structured along the same lines as kind of a phase-in benefit where your benefits expand or certain options improve after you've been here for 12 months. But essentially this rewards that kind of long-term residency in the state of Oregon. Again, trying to prevent people from just hopping into the state, receiving healthcare, and then hopping back out, but really establishing this as, part of what it means to be an Oregonian. There is definitely some administrative complexity to whatever is set up here, whether it's cash or whether it's tax credits or, like I said, this one it's a lot of things. It's exciting and a little overwhelming, I think, because it could be so many different things. And yeah, I don't want to put too many ideas out there, but this is one that definitely is looking to create a program that acknowledges the fact that, you're residing in the state and you've been residing in the state long term. All right, next slide. Let's take a look at this summary table. So give everyone a minute just to go through this, but really we were looking at having kind of that simple immediate enrollment for everyone, one where there's that limited window where you need to apply, another where there are phased benefits. I think our proposal mentioned 6 months. That could easily be adjusted if this committee thinks shorter or longer is better. That credible coverage where we get that smoothing of folks that have federal dollars attached to their healthcare. And then that residency tenure benefit. And you can see there's, lots of different ways to look at it from enrollee perspectives. There's some complications with all of them, except for the first one where it's the same. Under some of them, benefits do change over time. Some of them are designed to address migration concerns. There is some amount of additional administration needed for all of them. So it's really just pick which one you find the most palatable. And as far as the healthcare spending, just noting that, there's a surcharge offset where there are phased benefits, you could expect to kind of control those initial costs of new residents. Same with that residency tenure benefit. And I'll be quiet. Yeah. All right, I guess, yeah, let's continue on. I think I do have a few more. I apologize. This one's pretty intense. Here we go. So key decision points, things that it would be great just to get the temperature of this committee on. That residency definition, currently based on the tax filing, but open to any discussion if folks think that that's maybe not right. proof of intent to reside. This is going to really be a key one. Folks that have been here for a while and filing taxes, that's pretty straightforward, but what does that kind of acceptable proof look like? You know, sticking with the OHP sort of standard or something, you know, more rigorous. And then another question is that re-enrollment basis, whether it's going to be just, again, on that tax filing or re-attestation, and how to deal with those non-tax filers. So those are just a couple other thoughts. And I think that might be it. Next slide. Oh, just quickly to note, those different enrollment proposals, these are just some options for how one could potentially, you know, mix and match and even combine some of the different scenarios. For instance, having that, you know, simple one as a standalone, having one that's high accountability where there's a 90-day enrollment, along with the residency-based benefit, or having one that's really kind of budget friendly by doing the phased in benefits, et cetera. That there are lots of ways these can be combined. These are just kind of 3 examples. All right, and next slide, please. There we go. I'll turn it over to you, Chair.
Thanks, Lee. That was fabulous. I love seeing the entire buffet of the universe before us and be like, all right, and you can mix and match. Mike, did you have a question?
Yes. To lead, questions on 2 dimensions. I mean, one, I think we're going to want to have an understanding of is the relative costs, right? And the cost one is slightly complicated because we have we wouldn't be paying for something if something was delayed. On the other hand, we'd have some additional administrative costs. So this is tricky, but I think, Lee, if you could also comment on, you know, it appears to me in looking at this is not looking at other states, but other, you know, this has been done globally. Depending on how robust the IT administrative system is, will influence this. I think, and I guess we just haven't gone far enough there. So maybe I would just register that as a question for future discussion of to what extent if we had a very robust IT system that in terms of eligibility actually really worked well, we might be inclined to go one direction versus another. So those are just my two questions for you to consider.
Thanks, Mike. Other thoughts, discussion, questions? Thanks, Mimi.
Well, this is a little sneaky, but I will actually ask Kate Chanel from Milliman if she might be able to comment, not on the answer to the questions that Mike Leahy just posed, however, on the potential for finding an answer to those questions from the work that you're doing. Like, this is a little spoiler alert, but next month is going to be I'm so excited for Milliman's presentation.
Yeah, of course. Appreciate the question. Always thankful to be here. We have an organizational structure proposal for you that will come in December. And with that, we will talk through the IT needs. And we already had a preview with both Judy and Mimi and Lee and Isabel. And you're right. I think all of these options will have a different impact on the administrative structure, and that IT system will be very important here. So this is very helpful because we like to listen along to how this committee moves forward and then build that into our model. So we'll be able to adapt that based on sort of where y'all are leaning. But excited for next month.
Thank you, Kate. Glad to have you here. I have just a couple of general comments, and they're really just from my seat in the peanut gallery as a primary care doc, so you guys can tell me if I'm all wet. But thinking about the economics, one thing we know is the more frequently we require people to re-enroll, the higher the risk is that they won't, and they fall off of coverage. And so
Right.
I'm more inclined to, establishing their residency once and limiting how many times we ask folks to reattest to their residency. Although I know it's never going to be one and done, right? My other bias too is to option C, because from what we experienced when the ACA expanded and we included a whole bunch of folks who um, were self-employed, just never had health insurance before, and we said, all right, congratulations, you have health insurance now. They didn't have a robust, apologies if you were doing this, but they did not have a robust orientation to how to access care and a warm handoff to a primary care doc. So when you have a gradual uh, increase in benefits, like you're going to cover emergency care and pregnancy and these things that you need day one, right? But then you encourage this establishment with primary care during those first 6 months. That's when you can really start to develop the relationship that helps you to navigate the system. Tell me you're talking about gatekeepers without saying you're talking about gatekeepers. Yeah, basically, right? It's like, how do you get the care you need when you've never had it before? How do you access this weird care in Oregon when it's the first state in the union that's actually tried to do this? And so that gives a bit of a model built in. That's just my opinion. Happy to be proven wrong. Yeah, Lori.
So a couple of things. One is that the one with the tiered system of you get preventative care and then you get access to more expensive care, basically. But I guess what I worry about is you'd have to build in a board to review all that. I mean, you have car accidents, you have people who, what is a chronic condition that would be considered to be eligible immediately for, more hospital or expensive care. So I think that would be a little tricky. The idea that you have 3 months to enroll if you have people who have lived in the state and are not used to, as you brought up, having health coverage, and may not occur to them to think about it until, sorry about my dog, may not occur to them to think about it until they have an acute problem. What that looks like, are those people because they didn't get it? I mean, where do you start and end the 3-month time frame? I guess sounds like it could be complicated. And I guess my bias, of course, is less money for, right now, so too much money to administrative costs. And so I think simple in the long run will pay off because you'll be getting more care and less of it'll be going to, paperwork.
Great point. Thank you, Lori. Anne.
Okay, just in terms of implementation, D and E look to me like they're kind of procedural and they would tuck under A, B, or C. I don't think they are standalone plans per se. That being said, like Lori, and Judy, I like the idea of a limited window where you can build relationships and start the patient education relationship.
Great thoughts. Other thoughts? How does this sit with folks? Hi, Paula. Oh,
Hi, I'm
there
here.
we go.
Up and down. Yeah, it's just is a little bit to take in for a minute, trying to think, because I go to also the simple, but I mean,
as far as keeping administrative costs down, but also knowing that I think tend to lean towards just having a little bit of structure, not like everyone. But also what Mike said about that's part of what I was thinking when we were going through the slides is how can we use IT and how can we use data and systems to streamline that some of these and not really knowing like it's a little I like have to think about it or I think that's part of what we need to do, right? Because each one of them has ramifications and what options would we have to streamline this option versus this option and so forth. So I guess that's all I have to say right now.
Yeah, thank you for that. Yeah. Mhm. For sure. Yeah, this as well as the model discussion dictates a little bit about how big that IT bread box needs to be. How robust does it need to be, which then implies cost too. Yeah. Lori, go ahead.
So I guess another thing is what the plan will cover when a person is out of state for people who are perhaps, I'm thinking about kind of snow bunny retirees who are, 6 months in the state, 6 months out of the state, or people, if you talk about not wanting to have people re-enroll too much, if you're too robust in what you offer, you could have people choosing to live out of state and keep their Oregon plan, because it's probably would be a better deal for them than having to think about, the insurance issues in whatever state they're in. So I was just curious. I'm sorry if I haven't read some of the detailed information that the other committees have talked about, but what have they talked about with regard to this issue?
Mimi, has finance and revenue discussed this? And my thinking, Lori, about that would be, if your coverage in Oregon for X procedure is, the cost is $2,000, presumably you go to Arizona, you get the same procedure, Oregon will cover up to $2,000 is one idea. But I don't know.
Yeah, I would say that the specifics, again, because it is a little bit more of a operational question. So in terms of the specifics haven't been discussed in finance and revenue.
It's a great question. Let's make sure to write that one down and can get to it. Anything else bubbling up? Yeah, Mike.
Yeah, this may or may not be germane to this, but there's a phenomenon called medical tourism, and that's a liken to this Arizona, Oregon piece. But medical tourism internationally is a very big business. So it may be another factor we might want to toy with, just like that question of the snowbird, or what was it, your term? The someone in Arizona and here, yeah. And I also think this is obviously going to be very messy with between the Portland area and Clark County. People may be taking advantage of certain things. So this is an excellent table, Lee, that you've developed. It really makes us think about this deeply.
Agree. Well, once again, my inclination, because these are really complex topics with lots of options, is to give this to the committee to think about. Think about this in the interim between now and our next committee meeting, and we can bring it back for discussion. If you have immediate questions or there's a, oh yeah, but what about, then send an email to me and Lee. I'll send it to Lee. Help us out, Lee. Do some policy analysis and get back, which is really a blessing of having great staff. So thank you. Yeah, Mimi.
I know. I was wondering if we could summarize kind of the sort of data points or things that you all feel would be helpful. I think one thing that I heard, and I'm not sure how drilled in we're going to be able to get to this, but it does have to do with cost of a more extensive system. And that's why I'm going to call on my friend Kate, if she might be able to look into that. Obviously, we'd have to give them some parameters, but maybe even if we get a general sense of a cost and a percentage increase for doing one over another, that might kind of be helpful. So that's one thing that I heard, but what are, again, I just want to make sure that we capture everything. Other specific question points.
Travel in and out of the state, what does that look like? How does that work? And to pull these threads together, this whole table here, we're thinking about, these are roles that the central universal health plan would do. They would help with establishing eligibility and enrollment. We wouldn't expect the regional entities to do that per se. Though, as Kate mentioned, they're bringing back models of how you would design this public trust and define the accountability and responsibility specifically to the regional entities versus the central universal health plan. Following along the lines of how do you build the care model for different entities. Paula.
Yeah, one of the things I was thinking about is if part of that was, we talked about, utility bills for residency, that sort of thing. And right now, the CCOs, for example, will work with some of the CBOs to even get that information. So the data could be coming from wherever the patient happens to be. And so then how does it get to the central place? So anyway, just a comment there.
Yeah, thank you. Others before we move on. This has been a great discussion. Do you feel you have some questions, Mimi? To consolidate?
Oh, yes, I do.
Good.
We've got things to bring back.
Excellent. Well, if you're ready, we can move on to transition committee.
Okay. I'm going to share my screen. And so I hope this is going to be really fun for us, because again, we are thinking, this really is actually thinking about how best to do things. And so transition committee development, it's all, this is kind of what we think that the work of the operations will eventually go into the transition. So the way that I thought I'd just kick this conversation off is kind of going over, there was already a work plan developed actually at the beginning by the board about the work of the transition committee, and we're going to go over that. There's objectives, there's tasks, there's some couple of deliverables. I also did just a couple very brief summary slides about, all right, well, what very basic groups are going to be impacted by this massive change. I mean, spoiler alert, everyone, but also others, some more than others. And then kind of what are the main components of a transition plan. And then the last part is just absolutely the brainstorming. I mean, okay, what of that initial work plan do we keep? What do we change? Most important to me is, what are we missing? Because I think like now is the perfect time that we can really start thinking about it so that we can move forward. So, sorry, lots of words, but so the initial objective, and should I make this a little bit bigger? Is that helpful? There we go. This is again from the work plan developed back in 2024, way to go. The main thing, identify these implementation strategies to move into a universal health plan. So that's one of the objectives. Another one, this readiness assessment of key partners and state agencies. And then also, and this one is interesting, so working with regional organizations to reduce complexities and administrative burdens. So it's something that we think about when we think about, you know, the other work that we're doing. And also, and this is a little added bonus snuck in there, not really snuck in there, address workforce challenges, because that is part of it. Now, it doesn't say solve workforce challenges, but certainly at least to address them and acknowledge them and think about them as we're building this plan. Alrighty. So the tasks that were identified, so again, going to identify the transition steps going from where we are now to the Universal Health Plan. Developed and conduct a readiness assessment of key partners and state agencies, including the Department of Human Services and the Oregon Health Authority. I will say that the Oregon Health Authority is doing their own readiness assessment of OHA. So we have that built into the work that's happening. We will need to reach out to DHS to, again, depending on what plan that is developed. And I think, Paula, like your comment about the interwoven nature of services, how might this be interwoven with DHS and how could that work, which would be beneficial. And I'm excited. I think there's some examples that are happening in Washington State that we might be able to use that. And then, you know, again, looking on workforce challenges and identifying strategies to mitigate those as we transition. More tasks. So readiness assessment, including but not limited to health plans, doctors, medical groups, hospitals, counties, everybody, almost. Identify how it will have an impact on the current health system workforce. So as I mentioned, I worked for a health plan. And there are a lot of people employed by health plans. And what if there were no more health plans? What would happen to that entire workforce? And that's obviously a little bit of a tongue in cheek, but we do have to think about that. And then, you know, people who work in healthcare offices, providers' offices, that their position may become redundant, which, you know, might be a good thing in one side, but also those are people who, you know, were presumably earning a living wage, presumably. And then determine transition costs. So also, not only the cost, identifying sources of funding too, because it currently are, and not to say that the Finance and Revenue Committee won't work on this, but the Finance and Revenue Committee revenue plan currently is for the ongoing costs. And so I think there's still certainly things to think about. And this is, again, for the Transition Committee, really thinking about those sources of funding. Deliverables, to provide this report, to develop these strategies to address workforce challenges, and then provide an interim strategy and legislative recommendations. So no problem, that's all. And so the other two, comprehensive plan with a transition timeline and steps needed, and then the estimates of costs and designated sources of funding. So they really put a lot of thought into this plan, and it's, you know, it does include a lot in it. As I mentioned, I wanted to talk just a little bit, because we were talking about this the other day about when we were at the board meeting, and talking about the enormity of the task and how it certainly is not, as you all are aware, is not simple. And I think especially in this committee in particular is really aware of the nature of what a sea change it would be for all of these different systems. So who's impacted? Well, everyone living in Oregon, and then, but there's also people receiving healthcare who might, and people who are paying for healthcare. And there's a lot of overlap in that Venn diagram, but it's not 100%. Healthcare providers and systems, certainly health plans, and then employer, you know, other organizations that are funding health plans. A lot of state agencies would be involved, and some federal agencies as well. So again, just thinking about, as we think about this transition plan, you know, all of those things. And of course, there's many more, obviously, they're all kind of interwoven into that. I don't, you know, I didn't call out like CBOs and other things, but And then this one, again, I apologize, this came out a little small, but so I don't want to lose everything. Key ingredients of a strategic plan. So we have to know where we're going. You need a destination if you're going to get there. And the final recommendations will be a very good part of that. But as we've talked about this, there's a little bit of that, of the jump from, and actually Mike had a great thing at the board meeting. He asked people to think about, was it 2035, Mike? I think was the year.
That's the year.
That's the year. So Mike Leahy wants us to think about 2035. Everything is fabulous. The plan is up and running and it's perfect. And how did we get here? But we do have to have that vision of up and running. And that's what's being developed as we're going along, and it will keep morphing. The readiness evaluations, I put partners support and how to gain support. This is it is going to be an important part of the transition plan. I like the idea of action plans because I think that really sums it up. It's not just different components, but it's really, I think of like a catalyst. How do you get from here to there? I think we really need to incorporate that into our transition plan. So what are the legislative action plans? How about operational? Infrastructure we know is going to be a big one. Knowledge transfer. So I think this is also important and sometimes overlooked. And then, of course, there is the administrative structure, but like leadership of all of this. How is that going to happen? Timelines, so many timelines, short, medium, long, medium, short, longish, medium, we need them all. Funding amount and the source, and communication strategy. I mean, that's just a tiny little word, but you understand the enormity of that as well. Okay, I'm going to go back here. And I hope stop talking. And I'm just excited to hear and just anything, and I can go back to any slides that you want to see, but just sort of, and it doesn't have to be in this order. If you like, oh, you're completely leaving this off of it, let me know. So I'll stop talking for a while.
Thank you, Dr. Mimi. Yeah, Mike.
Well, I'm probably talking too much here, but here goes. You know, if we're thinking of transition, and I think this is implicit with what Mimi you said, but maybe we could make it explicit. We need a whole training and reskilling aspect in a transition, right? In other words, to the extent to which people are going to potentially get laid off because they're let's say a billing clerk. We're going to need a whole bunch of new skills in the other organizations. So, and I don't, sometimes we just call this, manpower changes, but there's a bunch of there's a bunch of skills that could be transferred into the new organization. So you might do less of a certain thing, but there's going to be usage of information technology. I mean, I had experiences years ago when I was asked to do some work when people were being laid off in the auto industry, to get them to be retrained in information technology in the Detroit area. It's that kind of example that you won't be able to do that to everybody that's currently working in healthcare, but a value I think we have is to be as humane and respectful of fellow Oregonians as possible. So it'll be if Mimi, you could think about maybe putting that into simple language.
Thank you for that comment, Mike. Absolutely. Lori.
Just to add to that, Mike, I think the federal Medicare for All bills with Bernie Sanders, he kind of included that retraining piece as part of his conversation about, you know, what components that would need to be a part. And I have two really big concerns with transition. One is I worry about companies like United Healthcare with the vertical integration that have so much, it will be impacted so completely with clinics, pharmacy, and health plan, and their insidious way of undermining things. You know, I don't know what kinds of conversations have gone on already. But, you know, one thing, as you were mentioning, if we do have a population of people who are potentially going to be impacted with their jobs, they're going to be more susceptible to any kind of negative publicity because, you know, they are going to be feeling anxious and uncertain and, you know, more. So those are things. And then I think in the long run, a lot of people are going to go along with this if their if their primary care provider embraces it and recommends it. And I feel like, you know, I work in a federally qualified health center and I have a lot of conversations with colleagues, and I feel like they're not on board as much as we need them to be. I think a lot of their concerns stem from how is this going to make life harder for me? You know, they have this idea that somehow if we actually have a better healthcare system, there's going to be double the patient load from and they're already feeling overwhelmed. And I just think that we really need to be proactive in trying to figure out how to empower them to make this change.
Thank you for that, Lori. Yes, I think I have this feeling after this first annual report, and especially as we're getting a bit more consolidation around a plan from the finance and revenue side, that we're approaching this sweet spot of it's built enough that we can talk about it in an informed way and confidently with Oregonians, because to this point it has really been, you know, a vision rather than a actually a half-built thing. But I think we're getting there to where we will at least know enough of the structure in which way the board is directing this final plan so that we can articulate it in a way that's satisfying to all of the constituents, including providers and patients. And
Yeah, and just to continue on that thought, one of the things the board's been talking about is if you remove administrative complexity, you have more time for clinical care. But my point in terms of gaps or missing areas, just to be more specific, frequently you have to have a purchasing plan, supply chain management, actual action plan around that. And in particular, the pharmacies, usually one that you really have to drill down on. And then just policies around vendor management for different kinds of services that you're going to outsource.
excellent. Excellent. Great point. Other thoughts?
I'm wondering if I might pose another question, since I want to keep everyone too long, but just since we're here and I have you here, what when I talked about what are we missing, I was thinking of like part of the plan, but also sort of, to overuse a business phrase, subject matter experts, like what will be the groups or people or, you know, that you think will be really beneficial to bring in for advice on a transition plan, on creating the plan. I know, I mean, everyone's going to be involved eventually in the plan, but in the creation of a transition plan. Oh, Sarah.
Can you hear me?
Yes.
Okay. Oregon Nurses Association. That's number one. Number two, Oregon Healthcare Association. And if you don't know who all that serves. That's for the one people who run memory care facilities and I think skilled nursing homes and long-term care homes, and it's a big association that I'm aware of.
Yeah, the QIOs and the QINs.
Who is that, Anne? What's that stand for?
Oh, but frequently Centers for Medicare and Medicaid has vendors who help with quality assurance.
Gotcha.
So they're quality improvement networks.
Thank you.
I'll just build on what I was saying. I think nurses, there's so many more nurses than there are doctors. And we have less, I'm a nurse, we have less skin in the game. We don't make as much money as doctors. So nurses would be really good allies for in a lot of ways, communications as well.
Yeah, so I just want to be clear when I say providers, I mean all healthcare providers. I don't want you to think that we're, that we're only saying physicians or something like that. But yes, absolutely. Thank you for that. So true.
We have some of the community colleges teaching CNAs. Do you think that's too far out, or do you think that would be?
No, I mean, we've been talking about workforce things. Thank you so much, Anne.
Yeah, Lori.
Disability groups, their populations are very fragile, and they're usually impacted by changes. And if you could get them on board, that they would be very important. The other thing, now I lost my train of thought here. Oh yeah, if we're going to obviously be changing the VA and some of the other services in the state, yeah, even if it's a kind of an unintended consequence, so it would be good to perhaps get them on board in the transition, because that entails changes in their employment, et cetera.
Yeah, and I will say that question has been talked about, but not decided upon, about, especially around Veterans Administration and TRICARE. So people who are already fully covered currently. So that is, I had actually, while we were doing this, I put it on my to-do list and I realized it was already there. So then I just had to highlight it. Okay, well, I will, if any, same thing, any other thoughts, ideas? I've been looking for articles. There's a lot of business articles around this, and there's some general big transition plan change articles, but if anyone comes across any great, and I also reached out to Chen Wei-Chi for more information about Taiwan's their transition plan. So send them along. I know that this is an academic group.
Yeah, Lori.
And you don't have it down, but I'm sure you've been talking with the unions.
Yes, that has definitely come up.
Thank you. Okay. And next on our agenda is committee member reflections and next steps. I have two I'll offer up and then open it up to the group. One about next steps is we will hear, as Mimi alluded to, from Milliman in December, looking at the accountability and responsibility models that could happen with the central and regional entities, like how much ownership and authority and accountability do the regional entities have? So it's going to continue along this discussion, thinking about and around what do each of those levels do? What's the cost associated with it? What do we need it to do? All of those elements. So come prepared for another robust discussion. And my reflection is I am so appreciative of this committee. You guys make me smarter every time I come to this committee, and I never say that about a committee. And as we're discussing, I'm thinking about like the analogy that keeps popping in my head is when we converted to electronic health records. Now, when I was a wee baby doctor, I graduated into medicine with paper charts. And you can see my gray. And we had medical records teams who would go and run and find charts, literal charts, underneath somebody's desk or in somebody's bag or in some, maybe in the medical records office, maybe not. And all of those folks had to relearn an entirely new way of working. And some of them transitioned out and did other things. Some of them were trained, went to Epic and became, trainers themselves. My point is just, even though this is a monumental task and the ask is huge, we can do hard things, and we have. And so I think, continuing to bring all of this brain power to this work, and asking our consultants and shopping it around and building as much of it as we can, and then getting all of the input and buy-in from other Oregonians is going to be key. So we can do hard things. What else? Committee, any other reflections? Maybe any other next steps? Awesome. Do we have any public comment?
Not today.
Okay. Thanks, Isabel. Hi, Sarah.
Okay, yes. I jotted down a question in Lee's first presentation that I kind of forgot to ask before she moved on to, or they, I'm sorry, I don't know your pronouns, before the second presentation. And so on the public website, the second presentation slideshow is up there, but the one that I'm referring to was the shorter slideshow with the models, the 3 models. And the model that was most appropriate for like urban areas talked about the word integrators, or there was another word like that, connector or integrator or something. And I'm still, I know we keep on fleshing things out more and more, but I'm that's still a big gap for me is picturing that type of, I need to hear more. I need to keep hearing more about the integrator role.
Cool. Yeah, I think we can do some research and come back with more of that. Mm-hmm.
Yeah, great. And then I wonder if we've mined everything that would be helpful for us from reaching way back when OHP first unrolled or rolled out. And then just since I don't have the strongest operations background, for me, like reaching back a few meetings, the presentation on PEB and OEB details was very, very informative since they're very big systems. And I guess I could, go back to that meeting and find the links and figure out how to learn more. But that's definitely something that I want to understand more. Like, not that there's one operations manual at PEB, but what is there that's like a nice meaty, or even just the benefits. Like, I don't receive PEB benefits, so is that publicly accessible easily, or how can I read through some meaty, 50, 100 page wonky things to kind of keep wrapping my head around huge systems that serve, I can't remember the figures now, if it's 40,000 members or what.
Thank you, Sarah. We can find that information. One of the challenges is there's not like a single benefit package in PEB or OEB, like any of these entities.
Yeah.
There's all these tiers and they all have different packages, but our consultants are looking through all of those. And Milliman has done a pretty solid analysis of like the payment structure and what they cover in each of those tiers within PEB. And I've seen some of that work in the plan design meeting minutes and notes, and so we can certainly make that library it's available but maybe more indexable and easier to find stuff that's in there to help answer the question. I really appreciate the question. The integrator idea, part of that too is starting from the point where funding and financing for healthcare and behavioral health needs to be integrated, which it is not now, right? And so thinking from there, then what does it look like when you deliver the care? If you have financing is all in one bucket and not structured the way it is now, then what can we do with that? And how can we provide care in a way that is efficient and effective for the patients? Yeah, Lori.
I think about SAFE and the way that things are handled as far as workers' comp and how this system's going to have an impact on that. And the conversation with, here we have another public corporation that's been involved for a long time, and we will have some form of relationship with that. And so my reflections are always thinking about what are some things that we don't want to not pay attention to that could be a problem down the line.
Yeah. Mimi, do you want to talk about the conversations around workman's comp?
Yeah, absolutely. No, that I love it. I think I'm a safe stan. I think they do an amazing job in Oregon. They do tremendous work. In addition to, they're so much more than just kind of paying out money for people. So again, that's another one that hasn't formally been adopted, the plan for that, but it certainly there's a strong potential that workman's comp will still function mostly, not 100%, but like mostly in the way that it does because it's so successful. I mean, SAFE isn't the only workman's comp, but that's sort of the big public corporation. But anything you think of like that, Lori, like, ooh, don't forget that. Please let us know. Because, we are trying as much to capture everything, but it's very easy to overlook things. So I completely appreciate that.
Excellent. This brings us to the end of our agenda, but I don't want to end things prematurely if someone is waiting to speak. Thank you everyone for your participation this afternoon. I deeply appreciate it. You make me want to keep doing this work. So thank you. I hope for all of you, you can enjoy maybe some downtime next week and safe travels if you're traveling, and we'll see you all again next month. This is adjourned.
Happy Thanksgiving.
Thank you, everyone. Take care.
Thank you.